Hello everyone, my name is Natasha Rose and today I'll be presenting my eating and feeding disorder case study focused on a 10-year-old girl named Alice. In this presentation I'll go over her biopsychosocial assessment, list some differential diagnosis, and share what I believe is her primary diagnosis, and talk about both medication and non-medication treatments, including lifestyle changes. I'll also explain how I would work with other professionals to give Alice the best possible care. From a biological standpoint, Alice is a 10-year-old who was born prematurely at 34 weeks. Even though she caught up developmentally by age 2, she has always been small for her age. Recently, her weight dropped from the 25th percent down to the 5th percentile, which is a major concern. Her physical exams have been normal, so the lack of her appetite doesn't appear to be caused by any medical illness. On the psychological side, Alice's eating issues seem to be tied to fear and anxiety, not body image. Her fear of vomiting started after she got sick from eating soup when she was 4. Since then, she's developed strong anxiety around food, especially eating in public. She becomes very upset at meal times and often cries when asked to eat more. These behaviors show that her eating problems are linked to a fear response, not a desire to lose weight. From a social standpoint, Alice's parents divorced 5 years ago, and she splits her time between their homes. The change in the environment could be adding stress and inconsistency around meals. She also stopped socializing with her peers and prefers to stay home where she feels calmer. Academically, she's very bright, but her anxiety may be affecting her social and emotional development. When you look at all these factors together, Alice's symptoms line up closely with avoidant restricted food intake disorder, where food avoidance is driven by fear and anxiety rather than body image concerns. So for differential diagnosis, the most likely diagnosis I believe is avoidant restricted food intake disorder. The DSM-5 describes the disorder as an eating disturbance that leads to significant weight loss or nutritional problems without the person having body image concerns. Alice's refusal to eat because of her fear of vomiting fits this perfectly. A second possibility is a specific phobia, emetophobia, which is an intense fear of vomiting. While this may be part of her picture, the avoidant restrictive food intake disorder is more appropriate since her fear is causing major nutritional and social consequences. Another consideration can be anorexia nervosa. But Alice doesn't express a desire to lose weight or any negative feelings about her body. In fact, she cried when learning about the risk of being underweight, which rules out anorexia. Lastly, generalized anxiety disorder can be one presented along with the avoidant restricted food intake, as anxiety seems to affect multiple areas of her life, not just eating. So the primary diagnosis I chose, like I said, is avoidant restricted food intake disorder. Alice shows restricted food intake, weight loss, and emotional distress, also all caused by fear of vomiting and not body image issues. So the treatment plan. So there's not really a treatment plan for this diagnosis, but treatment can target her anxiety and low appetite, like fluoxetine, a selective serotonin reuptake inhibitor, may help decrease her generalized anxiety and obsessive fear of vomiting. Dosing usually starts at 10 milligrams daily. It can be titrated as tolerated under close supervision. Then you have the kyprophenidine. May be used off-label as an appetite stimulant in children with restrictive eating patterns. All these medicine decisions should be collaborative with a pediatrician to ensure safety and dosing accuracy. Therapy and non-medication interventions. The main treatment for this diagnosis is cognitive behavioral therapy. This therapy helps the child slowly face their fears around food through gradual exposure and positive reinforcement. The goal is to change how Alice thinks and feels about eating and help her rebuild confidence at mealtimes. Then we have family-based therapy is another effective approach. It teaches parents how to create a supportive mealtime environment without adding pressure or stress. Both parents can learn to work together to make meals calm, structured, and consistent across both homes. Behavioral strategies like exposure, hierarchies, relaxation, breathing, and positive reinforcement should be added. Alice can start by eating familiar foods in small amounts, then slowly work up to trying new foods or eating in different places. Lifestyle modifications. Keep mealtimes consistent between both households. Avoid pressuring her to eat. Focus on encouraging and calm conversation. Involve her in meal planning to give her some sense of control. Include light exercise like walking to help with appetite and reduce anxiety. Also track her hydration, calories, gradual weight gain with support from her care team. Interprofessional collaboration. I would collaborate with Alice's pediatrician to monitor her growth charts, vital signs, and lab work for nutritional deficiencies. I would also work with a registered dietitian, would design a balanced, individualized nutrition plan that gradually increases calorie intake. I would also consider child psychologist or behavioral therapist would lead to CBT sessions and monitor progress on her exposure to hierarchies. Also, the school counselor would be good. Should be involved to ensure Alice has a safe, supportive place eating during school day. Finally, without family, this would be difficult. So family therapy is important. It can strengthen parental communication and consistency across homes, addressing stressors related to divorce and meal routines. Thank you guys. I hope you enjoyed.